Hello! Today, we'll learn about Erythema Multiforme, an intriguing topic in oral pathology. We'll unravel the complexities of this skin condition, exploring its overview, pathogenesis, clinical features, histology, differential diagnoses, and treatment. From its name, Erythema Multiforme is a mucocutaneous condition manifesting as a red lesion which comes in multiple forms such as ulcers, blisters, macules, bullae, or plaques. Depending on the extent of mucocutaneous involvement and severity, it can be divided into EM minor and EM major for short, Stevens-Johnson syndrome, SJS, and toxic epidermal necrolysis, TEN, used to be classified in the EM family, but no longer are. Now that we've had an overview of EM, let's begin. EM is not just a skin condition, it's an acute cell-mediated hypersensitivity. It is found most commonly in people in their second to fourth decade of their lives, with male predilection in a ratio of 1.5 to 1, and with a prevalence of less than 1%. The lesions are seen to increase with immunocompromised patients.
Now, let's dive into the roots of Erythema Multiforme. EM is often triggered by a variety of factors, including infections, medications, and autoimmune responses. Let's uncover a multifactorial web of influences that contribute to the development of EM. In most cases, EM occurs due to an infection such as herpes simplex virus, 90% of the cases, or as a result of drug consumption, 10% of the cases. Infections that cause EM include viruses such as herpes simplex virus. It causes cold sores as well as genital herpes, bacteria such as Mycoplasma pneumonia, fungi such as Histoplasma capsulatum, which causes histoplasmosis. Drugs that cause EM include NSAIDs, antibiotics such as sulfonamides and aminopenicillins, anti-seizure drugs such as barbiturates. It is also worth mentioning that some researches suggest a genetic predisposition. Systematic illnesses that are associated with EM include inflammatory bowel disease such as Crohn's disease and systemic lupus erythematosus. It is rare to find a person who has both EM and systemic lupus erythematosus. When these two diseases coexist in one person, the condition is described as Rowell's syndromes.
Our journey begins in the basal epithelium layer, where cell-mediated immune response occurs in the area. The basal layers display their major histocompatibility complex, MHC1, which presents peptides to allow the cytotoxic T cells to attach. Normally, the cytotoxic T cells would only attach and target foreign peptides. In EM, the cytotoxic T cells bind to the normal basal epithelial cells and attack them, releasing cytokines such as tumor necrosis factor alpha, interferon gamma, and interleukin-2, which further attracts more immune cells. This deposits in the superficial microvasculature of skin and mucosa, leading to the destruction and necrosis of epithelial cells in the area. Moving on to the surface, EM's cutaneous manifestation varies from macules, vesicles, bullae, papules, or distinctively through target lesions on the skin and mucous membranes. These targetoid lesions range from 2 mm to 2 cm in size and appear with central necrosis and outer rings of erythema. Unless EM involves the mucosa, it is rarely accompanied by prodromal symptoms such as malaise, fever, and myalgia.
Zooming in to examine the histological landscape of EM lesions, we find apoptotic keratinocytes, which look like pink balls in the epidermis, signs of edema which look like white spaces, lymphocytes scattered across the epidermis and around blood vessels. In this section, the epidermis shows liquefactive necrosis, and there is a wide gap between the two layers of the epidermis and dermis. This wide gap at the interface represents a separation between the two layers. This is where the lesion's edema would be. The inflammatory cells like lymphocytes and histiocytes infiltrate all the layers and around the blood vessels. Now let's carefully watch how it happens. There are few lymphocytes at the dermal-epidermal junction. With time, more and more inflammatory lymphocytes are seen in the area and even around blood vessels. Basal epithelial cells start undergoing necrosis. subepithelial and intraepithelial vesicles begin to appear. Because these histologic features can be characteristic in multiple other mucocutaneous disorders, a careful clinical examination is necessary to make the final diagnosis.
Diagnosing EM can be tricky. This is due to the fact that there are multiple diseases which present the same clinical features and histology. However, most dermatologists rely on the careful history-taking and clinical features of the lesions without the need to do further lab tests. As we previously explained in the overview, erythema multiforme can be classified into minor and major, depending on the severity and extent of involvement. EM minor show typical target lesions, little or no mucosal involvement, and since it does not extend to the mucosa, there are no systemic symptoms. EM major show typical lesions, moderate to severe mucosal involvement, usually occurring in the oral region, and some systemic symptoms, fever, asthenia, arthralgia. In both cases, HSV is a predisposing factor. Stevens-Johnson syndrome and toxic epidermal necrolysis used to previously be part of the erythema multiforme spectrum, however, they no longer are. SJS and TEN are distinct disorders. SJS and TEN are more severe in their invasion and systemic symptoms. They are mostly caused by drugs. There is a phase of overlap between the two conditions as SJS progresses to TEN. Other differential diagnoses are urticaria, viral exanthem, bullous pemphigoid, paraneoplastic pemphigus, and fixed drug eruption.
Shifting gears to the practical side, erythema multiforme is self-limiting, so most treatment is symptomatic. This includes oral antihistamines and topical corticosteroids for mild cases, mouthwashes or topical steroid gels for oral disease. In EM minor, there is no mucous membrane involvement and no systemic signs. It is usually self-limited, so supportive care is sufficient. In EM major, where there is involvement of mucous membranes and systemic signs, demands corticosteroids, although controversial, and ophthalmology consult for ocular involvement. Early treatment with acyclovir may lessen the number and duration of cutaneous lesions for patients with coexisting or recent HSV infection.
In conclusion, we've scratched the surface of erythema multiforme. This journey serves as an invitation for further exploration. The dermatological landscape is vast, and understanding EM is a step toward unraveling its complexities.
Scan this QR code to access a patient-friendly leaflet to educate your patients more on erythema multiforme. Thank you for joining us on this educational adventure. Stay safe.